thank you so much for being with us this evening on what is Wednesday of Legs Matter Week. Say it, share it, change it. Really excited. I'm sure you're all feeling a massive buzz out there and can't avoid it on social media. It's been absolutely fantastic. My name's Beccy Elwell. I'm a lymphedema advanced nurse practitioner and I am the Director of National Clinical Services at Accelerate CIC. We are a social enterprise in North East London, caring for lymphedema and wounds. And I'm also a trustee of the British Lymphology Society and represent Legs Matter with them. And I'm delighted to introduce my colleague to you this evening. I will let her introduce herself, but we're going to have a lot of fun. So Tess, over to you.
Thanks, Beccy. Evening to you all. My name is Tess Henry. I am CNS tissue viability and lymphedema, and I am still in clinical practice. So I have a lymphedema clinic in Northamptonshire. My role with Hadnam is community clinical manager. So yes, jack of all trades, hopefully master of a few.
Oh,
lovely to be with you.
Master of many. Thank you, Tess. And really what we're doing tonight is we're focusing in on the really important message that the Legs Matter campaign has been promoting heavily, which is around avoidable harm. And this is something that we know that all of you believe in, but it's how do we raise awareness around this issue? And what is the real impact of chronic oedema as regards harm? And so Tess and I are going to go through a presentation together. We've got some questions for you to make it fun and interactive. And then we're going to have plenty of time for discussing any questions you may have or any cases. We're open to anything you might like to discuss. And while we're talking, there might be something that jogs your memory that makes you think of the one thing that you wish that everyone knew about legs and feet. And so please do share on your socials your one thing and that use the hashtag say it, share it, change it, and tag in Legs Matter as well. So without further ado, Tess, let's get started.
Lovely. Thanks, Beccy. Done it wrong. Oh, okay. There we go. Can you see my screen?
Not seeing anything yet, Tess.
Can you see it now?
Nope.
Okay.
Just try resharing.
While Tess is sorting her slides out, I'm just going to ask you guys to be putting your questions, if you do have any through the presentation, in the chat box or the Q&A. It's entirely up to you, whichever is easier for you. But if you think of anything, we will come back to questions later. So thanks so much. And we can see Tess. Perfect.
Yeah, that's perfect, Tess. Thank you.
No, thank you. Sorry about that, guys. There's a little bit of a delay. So, okay, here we go. So hopefully you'll enjoy the session. As Beck said, we want it to be interactive. So you all know, I'm sure, why it's important that we continue to develop our knowledge. So we're going to also have a closer look this evening on the link between the circulatory and lymphatic systems. And also the true impact of chronic oedema on wound healing. We're going to have a look at defining the stages of oedema and the importance of early intervention, and hopefully to gain a better understanding of compression solutions, so time permitting. So I guess this, when we look, and I'll keep this very, very brief, but when we look at, why this focus around, lower limb care, wounds, Julian Guest made two publications actually in 2015 and 2020 looking at the burden of wounds and the financial impact of that. But I think for me as a clinician, more than that, he highlighted that there were areas, where we were falling short as well, in clinical practice. So, one was actually defining the etiology, the actual cause of the wound. And let's face it, if we don't know what we're up against, how do we know how to actually manage that? So that started, a knock-on effect with, we had the setting up of the National Wound Care Strategy Programme, which was an NHS driven. We've got Legs Matter campaign, we've got the BLS, British Lymphology Society, Wounds UK. So all of these support materials are out there for you. So you don't need me to preach to you about that, because I've got far more exciting things, hopefully, to talk to you about. So I guess this is where you will see a lot of development in this area on study days. Yesterday, I attended the Society of Tissue Viability free study day. Absolutely fantastic day, packed with information. And there was a very strong focus around that link between the lymphatics and the circulatory system, as well as really honing our skills on, in the absence of red flags, compression solutions. So really looking at the science behind that. But what I really like you to grasp this evening is to walk away with a clear understanding of the link between the circulatory system and the lymphatic system, and essentially to highlight that when one of these systems fails, it inevitably has a knock-on effect, to the other systems. So again, this is just a little visual for us. We all know that the circulatory system, essentially closed system, so oxygenated blood via the arteries, returned via the venous system to the lungs for oxygenation, and around we go. What we're not very good at covering, and I can put my hand up here and say when I was certainly teaching in my tissue viability capacity, I never, dare I say it, I never ever included in my diagrams of the skin, the lymphatics. So the initial lymphatics, the start of our lymphatic system, actually sits in the dermal layer of the skin. So you're probably thinking, well, what has that got to do with the circulatory system? Well, if you have a look at that little diagram there, you can see a condensed image of the arterial blood supply, and then you've got that capillary bed where there's the exchange between the oxygenated and deoxygenated blood. And blood vessels leak out fluid into the interstitium, into the skin. And the job of the lymphatic system is, one of its jobs, I should say, is to actually mop that up. So remove the fluid and all of the other nasty elements that are sitting there. So bacteria, proteins. So it's one of the jobs of the lymphatic system to mop that up. So it really does play a critical role. So if you're visualizing with chronic venous insufficiency, and we know, the back pressure, so the venous hypertension, that in turn has a knock-on effect with the lymphatics. So if one fails, the other, it's certainly from a vascular perspective, we've got problems there. So again, this is just more of a visual, and also to just give you I'm just moving Sue and Becky, sorry. To look at the lymphatics and where they fit in. So they do maintain, as I said, the fluid balance by removing all of the fluid that's leaked out via the circulatory system, and it's also responsible for our immune response, inflammation and transportation and absorption of dietary fats. So it's really, really important. And I guess the two things that jump out to me there, especially when we're looking at chronic edema, lymphedema, on that point, I just want to, bring to your attention, we talk about lymphedema, chronic edema interchangeably, but actually, essentially, chronic edema is just a terminology that we're used to using in the community setting. But failure of the lymphatics, once you reach that 12-week point, and the edema fails to resolve itself, at that point, that's telling us that the body's lymphatic system is damaged. It's permanently damaged. And unfortunately, like valves in veins, it doesn't regenerate. So once we're at that 12-week point and the edema isn't subsiding, then, you know, we're in a state of damaged lymphatics. So, you know, for these patients, it's compression for the rest of their life. So, you know, again, I can't emphasize the importance early enough of stepping in, you know, when you see the edema, you know, and take action immediately, because it has a terrible knock-on effect with, you know, the compromising their immune system. Yeah, so they're a lot more prone to cellulitis, because of that compromised immune system, amongst other things. So one of the things that I think it's important to us as clinicians, especially in the community, is to be aware of CAP, the CAP classification tool. So it's something that is more commonly used in a vascular setting. So when I'm out and about and doing my thing, and I introduce CAP to a lot of clinicians, and I say, are you aware of this? Are you familiar with this? And the majority say no. And I'm talking like generalist practice nurses, community nurses, and that's totally understandable, because, as I say, this was a tool that was previously only used, you know, by vascular teams. But it's so important for us, especially when we're looking at early intervention. You know, when you look at the CAP classification here, right from C1, C2, C2R, you know, at all of these stages, a lot of the most recent vascular studies are showing that edema is present in just about all of these stages. So, you know, we really need to be picking it up at C1 whenever we're doing our holistic assessment, and we know that the patient has, you know, past medical history that would make them susceptible to venous insufficiency. So we need to, as part of our holistic assessment, make sure that we're looking. And I know you do it. I know you do it every day. It's just that we're not necessarily documenting it and formalizing it. So if there's one thing that I personally would really, really urge you to do, is to document what you're seeing, and more importantly, take action, you know, while we have an opportunity to reverse those stages of edema. So we'll have a closer look at some of that. So a little bit more detail here for you. I'll whiz through this. I think the easiest way to think of the lymphatic system is as a drainage system. So not only is it removing excess fluid, it's removing waste cells, immune cells, and proteins from the tissues. And as I also said, it is responsible for our immune response. So lymphocytes for, you know, moving bacteria, toxins, and debris, all via the lymphatic system. And that in turn triggers an immune response. So if you think we're reliant on the lymphatic system to trigger that immune response, if there's a break in the system, the chemical messengers that say, okay, this has happened, we now need to do this, we now need to do that. And the end result of that, when we're looking at chronic edema, lymphoedema, is that the body is kept in a constant state of inflammation. And actually that's one of our biggest enemies, you know, is that state of inflammation, because we know the damage that has. That's not even, you know, before we start accounting for the debris, the bacteria that's sitting in the interstitium, that's, you know, competing for oxygen. And so thinking of it in real terms, if we have a wound and we have edema above or below or around that area, we're really not giving that wound the perfect opportunity or the perfect environment to heal. So that's the kind of link that I wanted you to try and grasp this evening. And as I said earlier, responsible for absorption and transportation of fats via the gut lymphatics. So the lymphatic system as a whole, if that starts to fail, that potentially, and Becky, you know, we do see it where patients start to have, you know, major problems with, you know, the lymphatic system is so badly damaged that it's backed up into the abdominal region, and it's very, very difficult to manage. And of course, you know, we need that transportation of fats for transportation of vitamins, fat soluble vitamins, and proper synthesis of the fat. You know, if that's not managed, you know, we could be creating problems for patients with atherosclerosis and so on. So I could talk about this all night. I'm so naughty. So when we look at the lymphatic system, you know, what causes the lymphatic system to fail? Again, I'm going to keep it really short and sweet, but you might have heard people talk about lymphedema as primary and secondary. So primary in its simplest form, it's congenital, genetic, inherited. So whether that's an absence of, a malformation, or you know, it's not working effectively in one or all of the bodies sometimes. What we are more likely to see in a community setting is secondary lymphedema. So that can be as a result of surgery, radiotherapy, injury, trauma, or infection. So thinking about those patients again with cellulitis, remembering that every time they have an episode of cellulitis, that's causing further damage to the lymphatic system. So, you know, we really need to be getting these patients early. Malignancy, tumor, disease, the ones I've highlighted in red are the ones that I think are our biggest challenges in the community. So obesity, you know, we know obesity is a problem, it's on the rise, and you know, as a result of that, patients that are not managed become immobile. I mean, and young, very young patients, you know, are becoming immobile and housebound. And sometimes they don't always have venous disease. You know, they might just have obesity. It's cutting off their lymphatic flow. They end up with leaky legs. So proper terminology, lymphuria. And yeah, all sorts of problems that essentially are, if we're really being truthful, avoidable harm. Naturally, we have to have the patient on board as well, but other causes of edema, heart failure, liver and kidney malfunction, end of life, and I have put lipedema in there, although we're not going to talk about it tonight. Lipedema is a disorder of the fat cells in connective tissues, but we do have patients that progress from lipedema to lipedema and lymphedema. Okay, I'm going to hand over to Becky now for to kind of wrap it all up with the chronic edema and chronic venous insufficiency. Thanks, Bex.
Thanks, Tess. I think it's so, what's been so great is how you brought out the importance of the lymphatics and how they're so underknown and so underestimated in so many health conditions that we're going to start to learn more from some of the studies that are coming out. Lots of medical conditions are affected by the lymphatics, and then those medical conditions affect the lymphatics. So we're going to find out much more about this system as we go on, and how important it is. But also you brought out there the real close proximity between chronic edema and wounds, and how we can't treat them as separate entities. They are so interlinked. You showed that beautifully with the closeness of the blood circulatory system with the lymphatics, but also you talked about some of the complications of that, and wound exudate is lymph fluid. They are, so intertwined, that it was really good to hear that reminder on what's so important about not trying to treat these conditions differently, and thinking if there's swelling, people need to be seen by a lymphedema specialist. If there's a wound, that separates it. Actually, it's all needing to be treated together, as well as as you said, the holistic care of the patient, as well as their social background and things, which hopefully we'll have time to touch on. But the important part that we're still getting across in this really is about chronic venous insufficiency and its close relationship with lymphedema. and the lymphatic system. So as chronic venous insufficiency progresses, and we saw there that actually even at the early stages where this is just considered to be extremely mild venous changes, this increases the pressure within those veins. It puts extra pressure on the interstitium because it's bathed with oxygen and nutrients, as you said, Tess. But the problem is that the lymphatics cope, they mop up, they're a dustpan and brush for such a long period of time, resisting that pressure by clearing up, absorbing all of that fluid. We used to think the veins took away about 90% of that fluid and 10% was left behind for the lymphatics, but we've refuted that now. We know that 100% of interstitial fluid is removed by the lymphatics. They're much more accommodating of that interstitial fluid, but they can only maintain that function for so long before they become overwhelmed, overworked, underpaid. Some people will feel that way, and the lymphatic system starts to fail. And once it starts to fail, we start to see more problems arise with those skin and tissue changes, but also that big impact on mobility. So we start to see this chronic vicious cycle occurring. So as that pressure arises, that oncotic pressure arises, more and more fluid is pushed out into the tissues, along with those big cells you mentioned, Tess, the proteins, the debris, bacteria, and unfortunately we get, because of the immune function of the lymphatic system, when it's being overworked and overwhelmed, any infection will further damage the lymphatics. So that vicious cycle means that unfortunately, if you develop an infection, you'll develop worse symptoms of lymphedema. And remember, lymphedema is not just a swelling. As Tessa said, it's failure of the lymphatic system that leads to swelling, skin and tissue changes and an increased risk of infection. And then that living with that inflammatory state, as you said, Tess, is really damaging. And lymphedema is an inflammatory condition. There is that continual inflammation, which is probably the most avoidable part of harm, because compression is something that controls and reduces that inflammation. You know, not only does compression do the things that we know that it's able to do, contain skin and tissue, improve and reduce size and support tissues, increase venous and lymphatic return, but it also reduces inflammation, and that is evidence-based. We don't have an awful lot of evidence to go off, so it's brilliant that we have that. So thank you, Tess. Next slide, please. So when we're defining the stages of chronic edema and lymphedema and the importance of early intervention, as Tess said, it's stage the earliest stages of chronic venous insufficiency, we should be identifying that there is probably some concurrent edema. It may be fluctuating, it may come and go, it may not be there all the time, it might be standing, hot weather, flights, anything. But if you have people that report that they're getting swelling when they go on holiday, for example, we should be managing that. We shouldn't be ignoring it. Taking action, that avoidable harm, avoiding it becoming a permanent condition. And we know that at that watery stage, the low protein stage, it's much, much easier to treat. So the ISL category or staging of lymphedema, you can see below there from 0 to 3, with 2 stages in stage 2, stage 1, stage A and stage B. I would argue that Tess and I probably, apart from maybe our own family members, haven't met anyone at stage 0. Very sadly, nearly everyone we see has some evidence of edema. So those subclinical patients, those are the ones who are at risk, but they haven't actually as yet developed any swelling. We're not fortunate enough to see those, but actually in primary care, if we could raise awareness, that everyone got that, that would be great. Stage 1, where the swelling reduces with elevation. Those are the ones that fluctuated, go on holiday, stood at a concert, those sort of things. Stage 2, sadly, is where most of us will encounter patients. That's where most of us get to meet people, where they've got a swelling that doesn't go away anymore. And the tissues may still be pitting, so still watery, but it is a permanent change. And then stage 2B is when there are some skin and tissue changes, which again are permanent. They can be improved, but they are more permanent. Stage 3, sadly, though, is where a lot of you will encounter patients where they have more significant lymphedema related skin changes, which we're going to have a look at in more detail. So get your fingers ready on the keyboard. And what do you see here? So this photograph is depicting lymphedema related skin and venous related skin changes. So what do you see here? If you can type in the chat, there's no right or wrong answers. Are you choosing A, B, C, or D? And we've been a bit mean. There's no middle for diddle. Bit me. So most people in the chat are identifying correctly that this is hyperkeratosis along with papillomatosis, two symptoms of lymphatic failure. They are commonly seen in patients with long-standing stage 2B or stage 3, more commonly in the ISL staging. They often are concurrent, seen together, but of course you can have one without the other. And really, there's lots of information and evidence out there about managing these, which we'll hopefully have time to touch on. But primarily compression, yippee, yet again, is the mainstay of treatment. Next slide, please. And what shape changes or change can you see here? So we've got deepened skin folds, square toes, distortion, domed dorsum of the foot, and upside down champagne bottle shape. So you can choose more than one here if you can see it. And again, if you can put those in the chat, just use a comma to separate if you're choosing more than one. This slide is a patient who, again, I would say is a fairly typical patient that we see in the community with a stage 2B to stage 3 on the ISL staging of changes. So a lot of people are putting in the chat here that they are seeing the domed dorsum of the foot. That seems really obvious. Some people also saying distortion of shape, which I would absolutely agree with there. Some people are saying square toes, 100% is absolutely right. Some saying A as well, deepened skin folds, that there's really deep creases at the base of those toes and around that ankle. So I would definitely agree with that. I think the only one that I would say that wasn't so obvious was the upside down champagne bottle shape, the inversion that we see with lipodermatosclerosis. But that's not to say the patient doesn't have multiple issues, because as we know, chronic edema and lymphedema can hide some skin changes that can become apparent when the volume is reduced. So what skin changes or change can be seen here? You've got a real long list here that includes hyperkeratosis, it includes lymphorrhea, so leakage of lymph through the skin, lipodermatosclerosis we talked about just, inflammation, cellulitis, bruising, petechia, and trauma. You can put your answers in the chat, and if you can put 1 and then A, B, C, D, E, F, G or H, and then if you can put in 2, what compression therapy do you think this patient has been receiving? So have they been having bandaging? Have they been having a leg ulcer hosiery kit? Have they had made to measure compression, which we think more of in the flat knit area, or compression hosiery off the shelf, maybe more circular knit, although we know that's not an exact science? Or do you think they've had a compression wrap? So we'd be really grateful if you could put your answers in the chat. Great variety of answers here. Okay, brilliant. They've slowed down now to those choices. So I think for Tess and I, this is the type of patient that we often see. And this is where there has been some compression therapy in place, as we've alluded to there. And this is highlighting as well that darker skin tones make it more difficult sometimes to identify erythema and redness, and therefore we look at lower limb inflammation and inflammatory change, which is what the British Lymphology Society's lower limb inflammatory pathway is about. So here we can see some hyperkeratosis, most definitely, particularly around that medial malleolus area. I can't see any lymphorrhea, so I wouldn't have said B. And lipodermatosclerosis, I don't think we can see here. But again, it is more difficult with darker skin tones. And we would never say never. There are no wrong answers here. Definitely, there is some inflammatory change. I think we would say that that's sometimes harder to pick up on with the dark skin tone, but I think there is. I don't think there's an acute spreading cellulitis, but if a patient was saying that this area was hot and felt different for them and was painful, then we could certainly be looking into that to see if there was an infection. There's no bruising, that's not showing as bruising here. Petechia is an interesting one, a pinprick area of trauma usually, and we do see that sometimes from bandage trauma, but I don't think that's what we're seeing here. And again, the bruising and trauma fits in with that, with the darkness that we can see, but that is actually more inflammatory change. So the compression therapy we thought that the patient, well, we actually know, that the patient had been receiving was that they'd actually had a wrap in situ, a compression wrap, but only a leg wrap from ankle to knee. So what's happened is there is that collection of fluid above the knee, which has distorted that area. And also they didn't have a foot wrap. So that foot has also expanded with the edema displacement. So there's plenty of room for discussion. No rights or wrongs, as we said, but we hope that's been useful. Tess, over to you.
Thank you. One of my favourite slides here, believed or common obstacles for compression. So I'm not here to preach to you guys at all, but just more to bring these things to your attention, because my second challenge to you tonight is to ask yourselves these questions. So what's it really all about? You know, ABPI, fear of compression. So there's no ABPI, I can't apply compression. So thinking about early intervention, necessary and immediate care with National Wound Care Strategy says in the absence of red flags that we can apply and should be applying up to 20 millimeters of mercury compression. Okay, so I'll leave you to think about that. Inexperience with bandaging, can't bandage the toes or above the knee. The patient doesn't want to wear compression, they've refused compression. So just explore that. I really do urge you to explore that, because 9 times out of 10, a patient has refused to wear compression because they've had a previous bad experience, you know, and that's normally because the wrong type of compression has been given to that patient. It's too painful to wear. It should never be painful to wear. Compression should never be painful to wear. Psychosocial issues, so you know that opens up a broad area. You know, do our patients have support to apply their hosiery or bandaging or wraps? You know, environmental issues. Yeah, so it's really looking at all of those challenges. I mean, these are things that I hear on a daily basis, and yes, I'm one of those annoying eternal optimistic people that, you know, when someone says no, that can't be done, or puts an obstacle in my way, I will find a way. And if I don't find a way, I go to Beccy and she finds a way. So another really quick point, guys, because I know, you know, we don't have a massive amount of time, and this is about your interaction as well. But one of the things that I really strongly urge you to embrace this evening, or to embrace as a whole, is to try and keep the selection of your compression solutions generic, okay? And the reason why I say generic is because if you can grasp the principles behind when and why do I use bandages, adjustable Velcro wrapping devices, leg ulcer hosiery kits, hosiery, so sized, circular knit, off the shelf, where do I use custom made, where do I use and why do I use British Standard or RAL European, how can I manage toe and foot edema? It's critical to understand the underlying principles of the compression solutions generically, because once you grasp that, it very, very quickly, combined with your holistic assessment, so what the patient can and can't manage, what's practical for them, for their lifestyle, and so on and so forth. Once you've got that, you can then go to the specific products that you have available to you to say, okay, I know I need RAL compression class 2 in a circular knit, because this patient's got a good shaped limb, it's a cone shape, so I know I'm going to be delivering graduated compression. So also looking outside of the box, you know, anyone who has a patient that you can find no compression solution for, please reach out, contact myself. I know Beccy would also say contact me, because there is always a solution. You know, we just have to be a bit more innovative sometimes, and never ever forgetting the importance of donning and doffing aids. There's a multitude out there. Or the importance of grip gloves. Doesn't even have to be grip gloves. A simple pair of marigold gloves are revolutionary, and I'm saying that for yourselves as well. Save your fingers for the future. The gloves make all the difference. So much easier to get on over the heel and to literally guide that hosiery up the legs. So some examples here, you know, for bandaging, leg ulcer hosiery kits, wrapping devices. There's a multitude out there. Toe caps, so these size toe caps. You've got compression hosiery, so you've got flat knit hosiery here, which flat knit hosiery you'll know because it's got a seam evident on it, and it is knitted differently. So I won't confuse the situation by going through all of that technology this evening, but custom made or flat knit hosiery you can do so many things with, and we really do so many things. Velcro, zips, we layer, we reduce compression above or below. There's, you know, so many different options. So if anybody does have that challenge, bring it on. And also looking at, you know, new and innovative products that, you know, are new to the marketplace and really fit in where, you know, when all else fails, it's like, oh, what can I do? So, you know, being aware of those. Okay, so we're back to our quiz again. So again, if you wouldn't mind putting into chat, so how many suggestions can you think of what should compression not cause or do? Please. Bex, can you see the chat?
I can. Yeah, we've got some really good answers coming in. Not cause pain, not cause damages to the skin. Yeah, lots of people saying discomfort. You know, we don't want anything to be painful or uncomfortable, and not cause any ridges. That's really important. Or breakout ridges with breakout edema. Indentation, so marking. Occlusion of the arteries is a perfect one to not have. Not be difficult to get on and off, not dig in or roll down, not increase breathlessness. That's really important.
Oh, wow.
Or numbness or tingling. No pressure damage. Increasing fluid into other areas, fluid overload. No irritation, that's a really good one. Not cause any altered sensation and cramps. Again, shouldn't cause any skin damage or ulceration. So some amazing answers
what
coming
a
in.
Crowd!
Absolutely.
What a crowd! Yeah, I think I should just finish the presentation now. I think that
guys, list is comprehensive.
Thank you so much. So as nurses, we know we are very visual. So all of those things that you wrote in the chat, you will see photographic evidence of that very thing, you know, things occurring. So really well done there. That was yeah, fantastic, and thank you so much for your contributions there. Bex, I'm going to hand over this slide to you, please.
Thank you. I mean, I think that what's really interesting about these particular patients is they are patients that we're saying is perhaps not the patients that you see every day, but sadly, we do see lots and lots of patients like this very frequently. And so if we look at the first patient, so the first picture as you're looking at the screen on the far left, this patient has a really, really I want to say a more common limb than you would think of, because unfortunately it's not as rare as one might think. Patients that don't have mobility, where they are not able to muscle pump by putting their foot to the floor to empty the vessels, the blood vessels and the lymphatics in the foot, in the arch of the foot, and then to activate that calf muscle pump, that heart of the leg. And so what happens is we end up developing a chronic edema, which is really difficult because it distorts shape so quickly and so markedly. And you can see here that the patient's toes, because of the doming of the foot, have actually become really difficult to identify the shape of that. And that therefore makes pressure damage much more likely in those areas because you've got that shape distortion. You've also got a foot that is far more difficult to enclose in footwear, and so many patients have bespoke footwear that can also have its own set of problems and difficulties around comfort, pressure, and those things. So working with the multidisciplinary team with these patients is so important. Bringing on board our podiatry colleagues, bringing on board our colleagues who are able to assist, as Tess said, as industry partners, as clinical practitioners that are used to measuring for garments for the patients with similar limbs to this. We'll all have our own individual limb changes, but for similar patterns. And actually, you can see the next picture is the patient who has been well maintained in compression hosiery. Once that's been well fitted and resized frequently, and thought given to the application and removal for skincare, assessment of any skin or pressure damages, very wide grip top on there, so we can see that that's not digging in, not causing any damage, but it's not slipping down, which is really important. And there's an improvement in size and shape there, which has probably been achieved prior to the application of compression with some appropriate bandaging, and we often use wraps in that situation as well. But of course, that would be using the wraps creatively, innovatively, to use a stump type bandage or wrap application. But we talked about the innovative products that are available now, and some of those products are suitable for patients to go into straight away. So where time is really important for people, for example, with edema and advancing disease, these innovative products can allow us a solution which is more timely and more active in where time is important, where it's of the essence. And they can be very gentle on the skin surface as well and not cause any trauma, which can be really, really important. The next patient here, you can see that there is very significant lobuli, skin folds and overhang, particularly around the inner aspect of the knee, the medial aspect of the knee, where those thigh tissues are overhanging. And what that means is it's very, very difficult to find compression solutions because most of them are utilised where we're more likely to see skin and tissue changes and sometimes skin breakdown or lymphorrhea, which is always or generally always below the knee. So solutions are focused on that below knee area. So patients are usually bandaged up to the knee very effectively, very, very effectively in the community setting. Sometimes compression hosiery is then fitted for more of a long-term maintenance aspect. And that again is usually an up to the knee garment. And sadly, what we get then is an increase in these skin folds and an increase in edema sitting in those areas. And this makes it very difficult because under those skin folds, we're prone to fungal infections, we're prone to skin changes. We get a lot of damage to these areas where they rest on seating or on wheelchair folds for patients who need assistance to mobilise longer distances. And what you can see on the far right here of the image is this lady maintained in her well-fitting, made-to-measure compression. This has been innovatively applied because she actually has an undergarment, which you can see there where there is that division, that fits beautifully up to the knee, but then this second garment, which provides uplift of those overhanging areas, enclosure of the whole area that's affected. And this person has some obesity, which has aggravated the condition. And by using a tight style panty top garment, we're enclosing that area, once again, lifting that abdominal fold to allow venous and lymphatic return, using that innovative made to measure. Thought again has been given. This is easier to manage. It's easier to get on the undergarment first with an aid and then the second garment, and the Velcro fastening at the hip allows that garment to be open while it's applied to make it really, really easy for the patient to manage.
Fabulous, Becky. You're just a walking encyclopedia. So we all want a Becky in our pockets, please. So some documents here that truly I cannot encourage you enough to come on board, like, you know, Legs Matter week this week, so shout about it. But please, if you're not aware of Legs Matter, go onto the website, have a look. It's packed with information, with support for both patients, relatives, carers, as well as clinicians. So there's a huge amount of information, and they're constantly doing things in the background, you know, to support us and our patients. But there are other documents that focus on a clinical perspective. National Wound Care Strategy Program, as I mentioned earlier. So that was a 5-year project that sadly now has come to an end. However, it is still a fabulous resource, and those best practice guidelines don't change. You know, the principles haven't changed. So a lot of the clinical pathways that we're using in practice now are as a result of the work that the National Wound Care Strategy Program team actually pulled together. Heart failure, remember one of those objections I said earlier, the patients in heart failure. This document is absolutely superb. It's so superb, it goes into so much detail. So I urge you all to read through that, and don't forget to pull on the resources of your colleagues. You know, speak to your cardiac specialist nurse, you know, speak to tissue viability, speak to vascular. Yes, we are all waiting a long time for referrals, but, you know, pick the phone up and just, you know, ask the question to get support. Yes,
can I just say, we've had, just while you're on that, looking for support, we've had a question from Boudica, who says, how do I learn more about compression solutions? As she wants a starting point, not too sure where to start. So while you were talking about support there, where could she go to get more support about compression solutions?
So this is really where our industry partners can be really, really helpful. So, you know, in simplifying it. So again, it's one of the things that I'm very passionate about sharing, you know, my knowledge to simplify that. So I can definitely say it's something that Hadnam Healthcare can provide from a clinical training perspective. And I would say that's probably the best, not Hadnam, but industry partners as a whole is a great place to start, because if you are speaking with the clinical advisor from those companies, you know, they're clinicians, they're nurses first and foremost, and so they will understand the challenges that you have. So I would say, I don't know whether you want to add to that, Becky, but I think industry is a good starting point.
Most definitely, and it doesn't matter where you are or where you're based. That's the beauty of it. And also, we are looking for people to become Legs Matter champions. So that might be a really good place to get some support from peers and colleagues and be able to ask questions. And we want you to sign up. So go to the Legs Matter website and sign up and find out more about how to become a champion. You're all here with us tonight because you're interested and engaged, and you didn't need us because answering the questions you already you've blown us away. But yeah, please come and join us, and we'll make sure that there's a link in the chat for you. And Eve is saying she's signed up already, so that's fantastic.
Yay!
And Boudica's saying thanks for the information about where to go for support, which is fab. And I think you had one last slide, Tess.
Yes, and sorry, I just have to, this is another one. This is the most recent document via the British Lymphology Society. This is also a fabulous document to take you through the practical issues of applying compression garments and wraps for the management of lymphedema. So remembering chronic edema, lymphedema, failure of the lymphatics, one and the same. So on the BLS, Beccy, I'm going to let you deliver this one.
Do become a friend member for free, because it doesn't cost you anything. You get loads of free resources. We link with Legs Matter. We're one of the partners. And this is where you can access the lower limb inflammatory pathway we were talking about. And there's a study day in October, which is perfectly free and is an introduction to lymphedema if people want to learn more. We have another Legs Matter webinar tomorrow, focusing on men's awareness. So looking at breaking some of the barriers for men with lymphedema, which will be fantastic. So I urge you all to join that. We have Matt Hazeldine from Lymph United and Gary Cooper, who will be presenting some research around that. And I know a couple of you have had problems seeing the slides. So the slides are going to be available on the Legs Matter website and on the YouTube channel as well. And thank you to Yvonne, who said good luck to everyone managing lymphedema and lymphoria, those wet legs, because we know how complicated it can be. But keep in touch with Tess, and thank you all so much. We haven't any further questions, Tess, so thank you very much for your time, and thank you for such an interesting session.